Hi everyone, I want to talk to you about cesarean section. Cesarean section is a familiar topic. Let's go. Cesarean section could be a kind of emergency operation. In that case, we call it emergency cesarean section. Why are we going to embark on emergency cesarean section? In other words, neither the doctor nor the mother thought that this pregnancy will end in cesarean section. Okay, what are the situations? One, fetal distress. Maybe from the topography and everything, you could find that there's late deceleration, there's meconium stain liquor, and the fetal heart is going down, bradycardia, and so on. We'll quickly rush to the operating table and get the baby out so that the baby won't die inside there. Severe preeclampsia, or some people will call it fulminant preeclampsia. There's high blood pressure here, massive proteinuria, blood vision, headache, right upper quadrant abdominal pain affecting the liver already. Now, with all these features, you want to get the baby out quickly so that the mother and the baby could be saved. HEP syndrome. I have just produced a video on HEP syndrome. Kindly check that, and I won't go into more details about that. HEP syndrome is simply hemolysis, elevated liver enzymes, and low platelets. It's a very horrible situation under which there's nothing to wait for than to get out the baby. And the best route is cesarean section so that you don't subject the mother and the baby to another stress again. Maternal exhaustion. Maybe this woman had been in labor for more than necessary number of hours. She's tired right now, or the baby is even a perineal, but the woman couldn't push. You apply fundal pressure and everything, and it seems you are not winning. Then the next thing is to wheel this woman into the theater and get the baby out. Obstructed labor, maybe cervical dystocia or shoulder dystocia. For any of those reasons, the baby is not getting out of the birth canal. You've done all you could, or you estimated that that would be the case. You try to ripen the cervix is not ripening. Then the next thing is to go into the labor room. Operating room right away. Cord prolapse. Nothing has been wrong with this pregnancy. Everything has been fine with the labor, and suddenly your attention is called to the cord that is protruding through the birth canal. Next thing is cesarean section. But you need to check for the pulsation of the cord to make sure the baby is still alive. And of course, with the heart rate. Okay. Uterine rupture. For many reasons, maybe this woman had cesarean section in the past, and now they are trying trial of scar of vaginal bed after cesarean section, and the uterus is ruptured, or this is a woman who had delivered many times, or oxytocin has been given and the uterus has been hyperstimulated. Anyhow, there's uterine rupture. The next thing is cesarean section. Abdominal placenta, very high blood pressure. The placenta has discharged from the fundus of the uterus and massive bleeding. The next thing is cesarean section or failed induction. You have told this woman from beginning that we're going to induce you. You've checked your bishop's call, try to ripen the cervix, and you put your oxytocin on, but unfortunately, it's not progressing as planned. Next thing is cesarean section. Under these scenarios, they are all called emergency cesarean section. Elective. There are so many situations under which you plan for cesarean section. It could be because this woman is consistent with antenatal programs. So with that, you could make the determination that this is going to be a big baby. Like this woman has gestational diabetes mellitus, or genetically the woman is just big, or the baby coming is bigger than the birth canal. For any reason, there's a situation called cephalopelvic disproportion. And that means that the head of the passenger is bigger than the passage of the birth canal. So the head and the pelvic, they are disproportional, cephalopelvic disproportion. So when that is the situation, the next thing is to plan for cesarean section, because you have known that this baby will be bigger and you've examined the pelvic inlet and outlet, and you've made that determination that this baby is bigger than the size of this pelvis. So you are going to make that determination. Madam, it's not likely you'll be able to deliver this baby by yourself. We will help. Breech presentation. Don't want to take any chances. Don't want to ruin the stress of 9 or 10 months pregnancy. So you plan that we are going to bring out this baby. Actually, some centers will set the theater while doing all sorts of maneuver when it is breech, while some centers will just go straight for cesarean section. The desire of the mother. The mother might feel that I don't want to pass through the labor pain. I just want to have my baby delivered by cesarean section. Herpes genitalis or severe genital warts. You've seen that during antenatal time and you've made that determination. You are not going to allow that baby to pass through this canal. Placenta previa means the placenta is below the baby. The placenta is presenting ahead of the baby, not using just the lane term. So some call it low-lying placenta. It has grapes. Okay, but anyhow, placenta previa, you plan elective cesarean section. Multiple gestation. Some places will try delivering a pregnant mother with multiple gestation, particularly if they are both presenting cephalic. And even some can maneuver, if the first one is cephalic and the second one is breech, they can still maneuver. But to be a safer side in many centers and be free from litigation, you plan elective cesarean section. Anatomical defect. Like I said, you've checked the pelvis and you know it is small in size or android, then you plan elective cesarean section. Delivery on a certain day. Maybe the woman wants the baby delivered on the day, maybe on her own birthday, her mother's birthday, her father's birthday, on her husband's birthday or boyfriend's birthday, or on her own birthday. Anyhow, they just want it delivered on a certain date. If the child is mature at that time, well, she's the one carrying the pregnancy, she could make that choice. And if you both reason that, okay, that's a good one, and you plan along. Cervical carcinoma, pelvic fracture, prior surgery like cesarean section, because it's not all women who had Cesarean section in the past, that must always have cesarean section if the cause is not recurrent. Recurrent could be common when there is an anatomical defect or cervicopelvic disproportion. But if the cause of cesarean section is as a result of emergency situation like cord prolapse or abruptio, and that is not the case right now, then there's no need to think that once CS is always CS. No, it's no more. You do many things. So we are going to have a separate presentation on vaginal birth after cesarean section. So prior surgery like cesarean section or myectomy could warrant elective cesarean section planning right now. Intrauterine growth restriction. You don't want to subject this young person coming into another stress. Some think it's not a big deal. Intrauterine growth restriction should pass through labor. Many people will want to save their head from any embarrassment, just plan the elective cesarean section and bring out the baby hale and healthy. What are the possible complications? Immediately, there could be blood loss and it could be massive. And when it's massive, there'll be anemia, hypotension, dizziness, or acute kidney injury, either oliguria or even anuria. Anesthesia effects. There's possibility of cardiorespiratory depression. Mendelson syndrome. I made a separate presentation on aspiration pneumonitis where I have talked in details about Mendelson syndrome. Kindly check that out because I will not go into details of that here right now. And there also I talk about paralytic ileus. So there's possibility of allergy to any of the agents used, medication or anesthesia and so on. Wound dehiscence, the wound can break down. Now, TT&B, transient tachypnea of the newborn with respiratory distress. The reason is that the infant has not passed through the birth canal. That's why babies delivered by cesarean section will most of the times have transient tachypnea of the newborn. It is transient, just as it's been described. There's possibility of urinary tract infection, pneumonia, lung collapse, which is known as atelectasis, injury to pelvic organs, even by the most careful surgeons, and mortality is possible, but very low. Maternal or infant mortality is very low. Late troubles could be small bowel obstruction from healing and adhesion. Adhesion and fusion of the layers of abdominal wall could lead to small bowel obstruction. Deep vein thrombosis when the woman is confined to bed for a long period of time, you can have DVT. And of course, apostatic pneumonia or nosocomial pneumonia and so on. Increased calcium, Cesarean syndrome, or pituitary hypofunction. When there is massive blood loss, that will affect the pituitary and that will have effect on the hormones that are released by the pituitary gland. Asherman's syndrome or uterine synechia, that is the fusion of the uterine wall. That later in life could lead to infertility when there's no possibility of the two gametes meeting to fertilize. Chronic pelvic pain later on, and of course, mortality not on the operating table, not on the operating day, but secondary to some of these problems like DVT leading to pulmonary embolism, pneumonia if not well treated, infections and so on and so forth could eventually lead to mortality in them, but very low. What are the advantages of cesarean section? There will be no labor pain. There will be decreased urinary incontinence. Most women who had delivered their babies themselves spontaneously over years will come down with urinary incontinence, particularly multipartum. It is life-saving, particularly in emergency situations. Now, in those days, in so many centers, in so many parts of the world, where facilities for cesarean section could not be found, the maternal mortality is very high and is still high to today. Proper planning could be embarked upon. In other words, when a woman had known that this is elective cesarean section and they are sure of the gender of the baby coming, they can plan effectively, include from the items to buy, the rooms to make up, and even planning with their superior at places of work or school, as the case might be, because you know when the baby will be coming. So you can plan your leave, plan your EI, plan everything, or trip, or if a grandmother will have to come, or grandfather will have to come, you have enough time to do the planning since you know when the baby will be out. Okay, incisions. I brought this out because it's significant. It's possible there's vertical or mainline incision, and that will be done when there is distress in the baby, or the mother is tired, or there is massive bleeding in the mother. All you are doing is you just want to go in fast. So when you need to get in fast, you most of the time go for vertical or mainline incision. But there's poor wound healing here, though there's less blood loss and there's less pain, and the incision will be made along linear arbor. The transverse incision of fenestil is the one that is commonly used. There's less pain postoperatively, decreased wound breakdown, increased healing because it is highly vascularized, and for cosmetic reasons, great. The incision on the uterus itself could be vertical. When it is vertical, it's either this is a breech fetus or this fetus is lying transversely, or there's placenta previa down there, or there is uterine anomalies in one way or the other, or fibroid is down. So you go vertical even on the uterus itself after getting in from the skin incision. But most of the time, the incision on the uterus is transverse. I'm going to leave post-operative care to another presentation entirely because I don't want to rush. I will not give you details. Vaginal delivery after cesarean section will be in another presentation entirely. Okay, if this is a planned cesarean section, please don't rush in until the pregnancy is about 38 weeks. And don't wait too long beyond 40 weeks because too late could mean placenta insufficiency and the associated problems. Labor room monitoring should prompt operating room to get prepared for emergency session. Why that? The unexpected may happen to the mother or the fetus or both. Preparations. It is multidisciplinary approach and its physiologists will be involved. And when they are involved, they will take care of hematological disorders like bleeding dyscrasia because they don't want you to bleed to death. They will take care of those that have high body mass index, heart disease, lung disease, and kidney disease. I'm going to ask history to rule all these out. They want to know if you have past facial or oral surgery because intubation will take place or may take place. People don't use general anesthesia often nowadays. It's more of spinal or epidural, but they're going to probably go over all this because you may not be able to tell. You can get in and get into trouble and want to use other routes. History of allergy to anesthetic agents will be ruled out. Transfusion problems, including the religious people like Jehovah's Witnesses who would not want to be transfused, that will be also asked. Any neurological disorder like multiple sclerosis, tumor, paralysis, spinal bifida will all be ruled out. Pulmonary diseases like asthma, COPD, or cystic fibrosis, all those factors that could affect the rate at which the anesthetic agent could be inhaled or that could affect the entire operative procedure will be taken care of. Cardiovascular diseases like myocardial infarction, implantable cardioverter defibrillators, pacemakers, cardiomyopathy. MVP is not most valuable player, is mitral valve prolapse. I mean, here in this context, okay? Some people are laughing there. Certain medications will be withheld, while some will be increased a few days before the surgery. So I cannot go into details of all of them because it's case by case, okay, no, kind of issue. Basic laboratory tests that could be done is complete blood count, renal function test, liver function test. They can group and cross-match because they may have the need to transfuse, know your glucose level, and of course rhesus factor that will warrant administration of Rogan, depending. If the mother is rhesus negative, the father is rhesus positive, and the newborn is rhesus positive, and this is the first pregnancy, Rogan must be administered. Pre-op medications like metoclopramide, ranitidine, omeprazole, or sodium citrate could be given. And you'll be told that your diet will be restricted. 8 hours for fatty meals before the operation, 6 hours for solid foods, and 2 hours for clear liquids. Antibiotics depends on the protocol at your center. Cephalosporins, macrolides, and penicillin, clindamycin, gentamicin, or metronidazole could all be used. If there is associated methicillin-resistant Staphylococcus aureus, then vancomycin could be given. Deep vein thrombosis prophylaxis like pneumatic compression, enoxaparin, or unfractionated heparin could be used. There's possibility of bladder catheterization, of course, that must be done regardless of whether it's general anesthesia or regional. The type of anesthesia that could be discussed with you, it will be general. That is now in decreasing favor across the globe. It's mostly used in underdeveloped parts of the world till now, but in developed countries, it is more of spinal and epidural now. And you have to sign consent for that. Well, don't let me say you have to. They will talk to you and tell you that you need to sign consent. The surgeon himself or herself will come, talk to you, or the resident in surgery department will come and talk to you. Neonatologists will be invited, particularly because we are anticipating problem in this child not passing through the birth canal could mean we might be faced with respiratory distress that is likely going to be transient tachypnea of the newborn. The midwives, neonatal resuscitation team will be assembled, all necessary gadgets in place and tested and be sure they're working. Nurses could be present in large number. Consent will be signed for surgery, and what else? You are good to go. Oh, not good to go home. You are good to go to the theater for the operation. In conclusion, regular antenatal visitations will give good assessment of you and the fetus. And with that, there could be good preparations on the mode of delivery. And when those ones are in place, we should be expecting a good outcome. I'm truly wishing all pregnant women safe delivery. Thank you. Kindly subscribe to my channel so that you can get all these publications immediately they are released. Thank you.